Thank you very much for the invitation. So I have no disclosures. So first, we'll talk about immunotherapy in colorectal cancer. As we all know, the management of colorectal cancer can be multidisciplinary, including surgery, chemotherapy, and radiation therapy. And in the era of precision or individualized medicine, we now are using targeted therapies in the care of our patients. But really what's taking center stage is the role, an increasingly important role of immunotherapy for the care of these patients. The role of immunology and oncology has been linked since the 19th century, and it was surprising to me to know that it was actually a surgeon who described it first, whereby he inserted some killed bacteria into sarcoma sites and noticed significant tumor shrinkage. So immunology is sort of a field that is a little bit foreign to me, but other than killing bacteria and viruses, our immune system is important to kill these cancerous cells. But these cancerous cells are quite smart, and so they develop ways of evading the immune system. And this is where immunotherapy with regards to immune checkpoint inhibitors has come into play. And for the purposes of this talk, we'll focus on two classes of immune checkpoint inhibitors, antibodies inhibiting the PD-1 pathway. So this is pembrolizumab, nivolumab, and dostarlimab, which really in the role upregulate expression of immune checkpoint molecules like programmed cell death ligand band 1. And these are all ways for the tumors to escape the immune system. And there's also the anti-CTLA antibody, which usually the CTLA lymphocytes act like a physiologic brake on the immune cells. So it's a way to also break that pathway. So as we all know, the majority of immunotherapy trial is important for MSI-high tumors. And I won't go into detail. All of us here know the difference between MSI-high tumors and MMR-deficient tumors compared to MSI-low and MMR-proficient tumors. But suffice it to say that there is something about these tumors that makes them much more immunogenic. And because they are much more immunogenic, they are important targets for our immune-targeted treatments. In the MSS proficient population, however, there is a subgroup of patients with a specific type of mutation that have a more favorable prognosis. And that's because, again, some of these mutations that are conferred to them predispose them to getting a high tumoral mutational burden, and they are much more immunogenic. And this is the POL or POLD1 mutation pathway that is also included in a lot of the immune checkpoint inhibitor trials in colorectal cancers. And so one of the first important trials looking at that was the Keynote 177 trial. And we had a lot of data looking at the role of immune checkpoint inhibitors as a second-line treatment in the metastatic setting. But this was really the first one to put the center stage on immune checkpoint inhibitors as a first-line treatment for our patients with metastatic disease. And it was a randomized controlled trial whereby patients were randomized to either getting pembrolizumab versus the investigator choice chemotherapy, either with FOLFIRI or FOLFOX as a first-line treatment. And you'll see here, after a little bit of a crossing of the curves, there is significantly improved progression-free survival with pembrolizumab compared to standard of care chemotherapy. And that is maintained. That progression-free survival is maintained. But we also see, so unfortunately, not everyone with MSI-high disease responds to immunotherapy. And this study also showed us that, while there are adverse events with immunotherapy, these are generally a bit better tolerated. So a lot of studies, and it's hard to go through all of these studies, but suffice it to say that we now have very robust data for immunotherapy in the MSI-high setting, in the metastatic setting for colorectal cancer. And there's a lot of ongoing trials trying to identify which one of these immune checkpoint inhibitors, whether or not in combination, and what, the timing. So there is a lot going on. But I think where the excitement for us really exists is what to do in the neoadjuvant setting and perhaps in the adjuvant setting. And so this is a recently published study looking at locally advanced rectal cancer. It's a single institution trial that enrolled patients with MSI-high tumors, clinical stage 2 or 3, and gave them an anti-PD-L1 inhibitor, the dostarlimab, for 6 months. And patients were to undergo standard of care neoadjuvant chemo or radiation therapy plus or minus TME if they didn't respond. But for patients who had a clinical complete response, they would just undergo observation afterwards. And so the primary objective was to look at the overall response rates of this type of immune checkpoint inhibitor. And they also wanted to look at secondary outcomes such as safety. So out of the 16 patients that they initially wanted to enroll, they enrolled 12 who completed the 6-month follow-up. And it's very impressive results. After 6 months of treatment and 6 months of follow-up, the 12 patients who had this treatment had complete clinical response. This was done by exactly the same way we follow our patients for watch and wait, with MRI, endoscopy, and physical exam. They also had PET scans and biopsies as well, just to confirm as an additional measure. But so it's really interesting. We have a 100% complete clinical response in these tumors. Whether or not it's generalizable, maybe not. More than half of these patients had germline MMR mutations, and so whether or not there's a difference and that's why they responded better is not known. Also, it's not clear what the optimal duration of therapy is. There's a small number of patients, and we definitely need longer follow-up. But it might be something that's going to be added to our toolbox when we manage patients with locally advanced rectal cancer. Another area that's quite exciting is the potential role of immunotherapy in the neoadjuvant setting for patients with colon cancer. And so this study compared patients with MMR deficient as well as MMR proficient lesions. And there is, in preclinical trials, the thought that you can maybe turn these cold MMR proficient lesions into hotspots for immune therapy, perhaps by giving them celecoxib or other types of agents. And so that's what they did in this trial. And basically, all patients underwent colonoscopy and biopsy at baseline for entry into the study. They all underwent a cycle of IPI and Nivo, then followed by surgery at least 4 to 6 weeks post the end of their treatment. And then they looked at their response, their pathologic response. And very interestingly enough, all MMR deficient tumors responded, with the majority of patients having less than 10% of residual tumor in their specimens. And even more interesting, I think, is that about a third of patients with MMR proficient disease, which usually would not have responded to any of our trials in the metastatic setting, and that's why they've been excluded largely from this, really had some good pathological response. So we don't really understand if that's particularly different from the metastatic setting and why. There was very few treatment adverse events, and there were no postoperative adverse events thought to be secondary to the immune checkpoint inhibitors. So this is just some pictures of how amazing the response has been. But, now what? So, we talk about watch and wait for rectal cancer because the morbidity of a proctectomy is quite important. But is the morbidity of a laparoscopic right hemicolectomy comparable to a proctectomy? Some people are talking about whether or not we need surgery in this setting. And I think that's going to be something that's going to develop as we understand a bit more. Also, it's hard to survey some of these patients, with rectal cancers watch and wait trials. We have our finger, we have the endoscopy that's right there. We have good MRIs. It's hard to do that with a right colon lesion that you have to survey every 3 months with a colonoscopy. Also, just similar to what we just mentioned, we won't know whether or not these patients are going to fail distally, and then we've lost our chance for cure. So what are the takeaway points here? So we have MMR and MSI testing. It's very important to do this for all of our patients. We can see excellent durable responses with immune checkpoint inhibitors, and it is currently first line for all MSI-high metastatic cancers. We don't understand exactly what to do with the MSS patient population in the metastatic setting. And the one caveat to that, as I mentioned, is the specific mutations that could respond quite well. So I'm going to segue a little bit into talking about circulating tumor DNA. And we have some challenges in taking care of our patients with colorectal cancer. One of them is, how do we survey for distant disease? Which patients would benefit most from adjuvant therapy without obviously over-treating them? And so, the detection of CTDNA has been very well correlated with the presence of what we call minimal or molecular residual disease. So it's disease that is micrometastatic, that we do not see with our eyes on our traditional imaging, but it's there present in the blood. We need a biomarker that can detect these recurrences and help guide escalation or de-escalation treatments. So cell-free DNA is DNA that's present in the body because our cells turn over all the time, and that's normal. The tumor DNA, that is fragments of the cancer DNA that have entered into the bloodstream, that's what circulating tumor DNA is, and that's pathologic. And that is changed by the tumor location, the type, the burden, the stage, and a bunch of patient characteristics as well. There are different types of CTDNA assays. Some of them are tumor-informed approach, so specifically meant to identify the tumor of the patient. So it requires a tissue biopsy of that patient and then sequencing afterwards. Or a tumor-agnostic approach, whereby we look at common mutations, and that's how we informed our CTDNA testing. And there's a lot of potential application for the CTDNA, what is so-called the liquid biopsy, either in the screening for the localized patients or the locally advanced, but also, and perhaps more importantly, in the metastatic setting. So what is the role of CTDNA in surveillance, and is there one? So what we do know is that CTDNA is much better than anything else that we have at identifying these micrometastatic disease. The rise in CIA happens much, much earlier, much more consistently. But also, there's a bit of a lag time until we see these tumors on imaging. So, the lag time has been at least about 8 to 10 months in some of these studies. But unfortunately, even despite us knowing that they exist and these tumor cells exist in the body and they just haven't found their nesting spot yet, it has not been superior to routine standard of care. And we've never been able to show thus far that patients' outcomes are affected. So, how can we use this to escalate and de-escalate therapy? I think there's a lot of really interesting research coming. But in this study, that's a multi-cohort study, one of their outcomes was looking at whether or not postoperative CTDNA will predict recurrence, and we know that it does. And also, we were able to identify patients who would benefit from adjuvant chemotherapy. But there's a lot of questions: the timing of the assay, the value and the quantification of the DNA. And so this is just some of the studies that are up and coming, and we hope to answer some of these questions. But I think it's important to mention this dynamic study from a group in Australia that looked at patients with stage 2 colon cancer who either underwent CTDNA-guided treatment, CTDNA-guided management or standard management. So if they had a high CTDNA after surgery, they would undergo chemotherapy, and if they didn't, they would not, compared to patients who are in the standard management group who would undergo chemotherapy based on the routine clinical pathological criteria. And importantly, this study showed that the 2-year recurrence-free survival in the CTDNA management group was non-inferior to the standard management group. So that's, I think, quite important. And as we understand a bit more about this, we'll be able to have some more meaningful conclusions. Because right now, it still doesn't have a role in our societies because we don't understand it yet. But I believe that we will, and if anybody hasn't watched Ted Lasso, they should, because I believe that we will find a role for it. Might not be just now, but we will. So what are the conclusions? Increasingly important role in surveillance, may have a role in treatment escalation and de-escalation, but there is something that's important, which is this lag time anxiety. So I think oncologists are going to be very resistant to treat CTDNA positive disease without knowing what the target is. And so how to test, what to test, and when to test is going to be important. Thank you.